It's great to be here today, and thank you to Scott and Dan for hosting me. I had a great morning meeting with some of your experts who, interestingly, know almost as much about Massachusetts in some cases as I do from some of their academic work. It's also a privilege for me to have Ralph Muller here, who some of you probably know is the CEO of this large UPenn system here. But he has a Massachusetts heritage, too, because we actually gave him his training. And so, that's kind of the way we view Boston and Massachusetts, is we train the best people and then we send them off to various outposts around the country so that they can exert their leadership. And so it's a privilege to have Ralph here. I now have to delete some of the slides I had planned that was going to embarrass the UPenn system because now Ralph's here. But because technology is so good, I took care of that in the last couple of minutes. So I'm here really to talk about the experience we've had in Massachusetts, because I think it has taught us and can teach the nation a lot about healthcare. But I just want to acknowledge, Ralph, that I'm in a center of healthcare and innovation here in Philadelphia. You had the first hospital in the country, you had one of the first medical schools, the first school of pharmacy. I know that CHOP and our children's hospital every year duel to see who's the #1 children's hospital in the country. I think some of those duels probably are a little silly in and of themselves. You're home to a very thoughtful and progressive Blue Cross plan, Independence Blue Cross. It's led by my colleague, Dan Hilferty. So I know you're not, you know about innovation and leadership in healthcare, but I'm going to try to tell you a story about Massachusetts that I think may be different than the one you know or you've heard, and as I said, may tell us a lot about what we can learn both here and around the country. I used to start these talks because people come to Massachusetts a lot from around the country and even from around the world to learn what we've done. And I used to start the talks very simply. I would say, "Hi, my name is Andrew Dreyfus, and I'm from the future." And I did that because I would get a few little laughs, but also because it was clear that we passed our law in 2006, so we were essentially 7 years ahead of the rest of the country, and a lot of what we experienced and learned might be useful. Now the future seems so cloudy with both the politics and challenges of the ACA. I'm not sure that line holds anymore, so I don't use it as regularly. So I want to tell you this story in kind of 2 chapters. So the first chapter is really about our health coverage law and the background to it. And as you'll see, I'm going to go a little further back in history, actually almost back to Ralph's era in Massachusetts, because I think it'll help you understand it. And then I want to talk about what I actually think is a larger, more challenging, but more important agenda, which is how we try to improve both the affordability and the quality of healthcare. And you'll hear potentially a central theme in both these stories, that I think what is perhaps most interesting and important about Massachusetts is not the mechanics of our law and how our exchange works or even how our payment models have developed, but how we as a community have come together collaboratively to strike a balance between this kind of perennial fight that goes on in healthcare between the regulation and the role of government and innovation in the market. And so you're going to hear that kind of theme about those two as we go through. So let's start by talking a little bit about coverage. Now, many people date our coverage reform back to 2006, and that's when our new law started. And early on, a lot of people wrote off our experience because they said, that Massachusetts, it's a deep blue state. It's a very democratic state. They started out with a very low number of uninsured people. They had a strong safety net system in the state. Is it really actually a useful analog to look at in lessons around the country? But I want to take you a little further back in our history because it wasn't always that way. And so Massachusetts actually has been debating and has a great kind of variety of views on healthcare. And some of that debate I trace back, partly my own experience, to the 1980s, when then Governor Dukakis, then presidential candidate Michael Dukakis, proposed and had passed a law that would guarantee universal coverage for everyone in the state. And I actually worked for the governor at the time and worked on this law. And it was very much fashioned the way democratic progressive policies were fashioned at the time. It had a very strong mandate that employers should offer coverage. That was the main Democratic idea at the time. It had strong rate controls on hospitals in the state, and it had a big regulatory structure to support it. Well, as you know, he did not become president. And then a Republican was elected governor of Massachusetts, Bill Weld, and he actually took an opposite tack. The law that the governor Dukakis proposed was repealed, and Governor Weld actually proposed and successfully got passed in the legislature a complete or partial deregulation, an end of rate setting. And so we have in Massachusetts this ongoing debate between, is it the market or is it government that's going to kind of be the arbiter of how people get coverage and how we promote quality and affordability in Massachusetts, and that balance. So at the time, the Clinton reform started in the early 90s, and there was a kind of general consensus that states on their own could not achieve comprehensive health care reform, that you needed the federal government to act. But after the failure of the Clinton plan, Massachusetts got back to work. We instituted some reforms. We put in place a uncompensated care pool, a mechanism to partially pay hospitals and other healthcare providers for free care and bad debt they experience when caring for uninsured patients. We reformed in the mid-90s our insurance market for individuals and small businesses that required a guaranteed issue, so no pre-existing conditions, and what we call partial community rating. And I make some of these technical terms because you have some experts sitting over here who study these issues and actually probably know more about some of these details than I do, so I'm going to try to get all my terms right. And then what we did is we expanded Medicaid. We got permission from the federal government to broaden Medicaid expansion, especially to children. And that act in Massachusetts actually led to the passage of the national CHIP law, which expanded Medicaid coverage for kids. So we were doing a lot, but we still had over 500,000 people in Massachusetts who were left out of coverage. And so at the time I was working at, as you heard in my introduction, at the Blue Cross Charitable Foundation, and we said, let's see if we can do this differently. Rather than trying to build an ideological case for reform, let's try to build a business case for reform. So we hired the Urban Institute to do a series of studies laying out a series of policy options on how the state could move towards healthcare reform. And it was a kind of a great timing. The governor, then Governor Romney, Republican interested in market reforms, saw these models that were based on a publicly run exchange, like the federal government, as an opportunity. We brought all the leaders together in a series of summit meetings, hospital leaders, health plan leaders, consumer advocates, physicians, economists, and others. And we had an interesting ingredient we had never had before. The religious faith community came together. So something called the Greater Boston Interfaith Organization, and I mention them because they'll become important later, also tried to make the moral case. We actually didn't need, again, to make the ideological case, but we made the business case and the moral case for covering everyone. And as a consequence of that work, our legislature passed in 2006 a law that looks a lot like the Affordable Care Act, more Medicaid expansion, subsidies for people to purchase private insurance, and a fairly regulated market. And just to remind you of the bipartisan nature of it, this is Governor Romney signing the law in Faneuil Hall, our historic building. You have a similar one right here, along with a trio of elected officials. You'll see they're all men, but half Republicans and half Democrats. And everyone gave something up to this, and they're not in the picture, but consumers who were kind of stuck on the old Dukakis idea of let's make it solely the employer responsibilities, accepted what was then a Republican idea of an individual mandate. That was a Republican idea for those who go back a little in your policy history. Insurers got potentially more members, but accepted even greater government oversight. Businesses did accept new accountabilities. And so our law looked a lot, as I said, like the federal law: individual mandate, some employer responsibilities, a state-run exchange, subsidized private coverage. It was such an unusual day in Massachusetts that at the signing, both Mitt Romney and Ted Kennedy, who had run against each other and were bitter rivals for the US Senate, made a few interesting comments. Romney said, My son said that having Senator Kennedy and me together like this on the stage, same stage, means supporting the same piece of legislation will help slow global warming because hell is frozen over. Now, Kennedy, never to be outdone, got up and said, my son said something too. When Kennedy and Romney support a piece of legislation, usually one of them hasn't read it. I'll let you guess which one was that. Someone who tried to maybe not talk about it during the campaign. No. So what did we accomplish? So we have the lowest rate of uninsured in the country. So you could see we started again from a low rate, but we got it down to 2%. Went up a little bit as the economy worsened in 11. And this is for adults. For children, the number is almost zero. Almost every single child, we could count by the hundreds the number of children in Massachusetts who go without health insurance. And so that was a major accomplishment. Most of this expansion actually came as a result of public expansion. So the Medicaid program and subsidized coverage. We didn't see a big disruption, and I'm going to talk about this more, in the employer-based market for coverage. So a lot of fears that when you pass comprehensive coverage reform, you're going to disrupt a stable, working market for employers. That didn't happen in Massachusetts. In fact, there's no evidence of a kind of a great fear that exists in the policy community, this concept of crowding out, that if you offer significant subsidies to individuals, employers will drop their coverage, and then the public costs of these programs will skyrocket. In fact, what happened in Massachusetts was that if you look, the light blue bar shows fall of 2006 before we enacted our coverage. The dark blue bar shows after that. And while public coverage certainly grew, so did employer coverage. And so this prediction, I call this, said the Rand and Urban versus McKinsey and Deloitte debate. And this debate continues. So Rand and Urban have these microsimulation models that look at the kind of behavior, economic behavior of choices that individuals and employers will make given a set of economic circumstances. And their predictions suggested that employers would not drop coverage, and that individuals would buy coverage, and that the employer market would be stable. McKinsey, Deloitte, and other consultants talking actually to employers have predicted and continue to predict that employers will actually drop coverage, that when subsidies are available for their low-wage workers, they'll drop coverage. We don't know the answer to this nationally, and this would be an interesting point of discussion, and we talked a little this morning about how private exchanges, for those familiar with it, will play into this. But the important message here is that in Massachusetts, employers did not respond to coverage expansions by dropping coverage. What happens to the actual care people are getting? And so we see across incomes, across medical conditions, and even across racial and ethnic groups that adults increase their usual sources of care. And this was very significant. And so while it hasn't ended the kind of health disparity in Massachusetts, because we still have some of that, it actually has reduced it in a significant way. And this has been a source of some academic analysis in the state. Also, public support for the law has remained very high. And so when you ask the public in 2006 or 2010, they're solidly behind it. Again, we never had an ideology problem in Massachusetts. Again, we really wanted to build the business case. And interestingly, these kind of figures apply also to physicians and other health leaders. So physicians think the law's working well, and they support it. So what are some of the lessons that we took from this experience for national healthcare reform? Well, first, as I said, we thought that it was really important that we made this about the business case for caring for people, not the kind of ideological case. And we've seen how troubling it is at a national level when ideology kind of trumps the kind of economics or the financing. So that was important. That, you know, we had one distinct advantage. So we passed the law in 2006, and we've amended it probably a half dozen times. New legislation, new regulatory action, sometimes just by consensus. We had conflicts, we had regular conflicts, and the stakeholders that supported the law would get together in a room and sort them out. Well, that's impossible to do at the national level, and that's one of the reasons. You know, the Affordable Care Act, because unfortunately of another Massachusetts event by the death of Senator Kennedy and the election of Scott Brown, that bill never got conferenced. It means the House and the Senate never could work out their differences in the bill. And that, it wasn't so much that the differences were so great, that's when Congress fixes all the problems of the drafting of legislation. So a bunch of smart people like, young people, usually like you, get in a room and they look through it and they say, oh, we made a mistake here, we made a mistake there. They never could do that in Washington. We did that in Massachusetts repeatedly. We kept fixing our law, and we need to get to a place nationally where we can have those kind of conversations. We proved that diverse coalitions are possible. It wasn't just Governor Romney and Ted Kennedy. It was business and labor. It was hospitals and health insurance companies like mine that don't always agree on everything. Correct, Ralph? It was, as I said, faith-based groups. It was a real mix of people, and you have to build them. And finally, and this gets us to chapter 2, the day the law passed, we knew that our biggest problem was not how are we going to implement the law, but how are we going to support it financially over time. And so one of the reasons we were successful in 2006 is the drafters of the law made an explicit political decision that we would postpone the conversation about cost till later. Because every time in Massachusetts and elsewhere, and this happened in Oregon and Washington and other states that tried to take on reform, they tried to do both coverage and cost. And the cost, which is a lot more challenging and often involves kind of carving up a pie differently, often subverts the ability to advance on coverage. So we decided to delay that, but once delayed, we knew we had to deal with it. So I now want to talk about what we've been doing. Maybe I should just pause for a second and say, on the coverage side, any questions? Things different than what you thought or experienced? Or we could hold, yes?
I'm just curious, how did you delay the discussion over costs? How do you do that?
How do you do that? Well, so we did it, I mean, we did it in two ways. First, we just said we're going to delay it. We were very explicit. Sitting in a room, people would say, and I remember sitting in rooms and someone would say, we got to deal with costs, and we would say, 1988, we tried doing that, the law was repealed. Clinton tried doing that, the law didn't pass. And so we just said the imperative was so great. But we did have a kind of secret weapon. So I told you we created a uncompensated care pool, so-called free care pool that partially reimbursed hospitals. That had about $600, $700 million in it every year. And that was a fund that was paid into by health plans and by hospitals. It was a redistribution mechanism. So part of the analysis that the Urban Institute did for us, we asked them, how much more would we have to spend if rather than buying care at the back end, often in emergency rooms for people, we bought insurance at the front end for people? They told us it was about $1.1 billion. So we knew that the delta was about $400, $500 million. That seemed achievable. Yeah. In a $25 billion state budget, that seemed achievable.
And you didn't have a CBO that had to score it.
We didn't have a CBO that had to score it. That was true, and that helps.
So,
yes.
So you talk about the like we sat down.
Yeah.
So this we.
Yeah.
And one of you hear this like in Washington that they fly out to their districts, they don't really know each other.
Yeah.
Like, are these the same people like in the past 10 years? That
Yeah.
Coming out, like, is it easier to kind of deal with conflict when you know that it's like a repeated game, I guess?
There is. We actually, at the foundation, we hired a former LA Times investigative reporter to kind of find that out. And so she actually wrote a kind of significant monograph, and one of her conclusions was actually that a lot of the players had known each other not just for 10 years, but for 20 years. And they trusted each other. And they trusted each other enough that we could make some arrangements, like we're going to postpone the conversation about cost, but we're going to come back to it. And so I think it made a big difference. And so I think trusting each other, but it was trust but verify, right? It wasn't, there were a lot of fights. There was a lot of yelling and all that, but there was an underlying basis of trust. Other questions? We'll come back to questions at the end. So let me go on and talk a little bit about our efforts to control cost. So I told you, Massachusetts is famous for its health care, but it's not just famous for the quality of its health care, it's also famous for the cost of its health care. And so this is a familiar chart you see with the US relative to other Western European nations, but Massachusetts, as a nation state of its own, exceeds the national average as the single most expensive state in the country for healthcare. And there are a lot of reasons for that, and we can talk about it, but it's certainly partly because we have a high concentration of academic medical centers that serve a lot of patients, not just for tertiary care, but other care. Does that sound familiar to you? High concentration of academic medical centers in an urban area competing with one another? I said I would take out all the Penn references, but and everyone was complaining about it. And so whether it was small businesses saying, you know, we can't hire, or whether it was consumers facing out-of-pocket spending. But the biggest alarm came, back to your question, came from state government. So this is an interesting slide. So let me just orient you to the slide. So on the left here, we have total healthcare spending in Massachusetts in 2001 and a decade later in 2011. So the light blue bar shows the spending in 01 and in 11. And so you can see it grew by 60%. Now, most of that is not because of our healthcare reform law. That's mostly Medicaid and to some extent spending on state employees' health insurance. But look at the other side. Look at the spending on other major categories of services in Massachusetts: public health, mental health, education, housing, human services. In fact, for those public health students in the room, these are the social determinants of health, right? This is health care. This is actual health. So while the state was paying more and more for health insurance for poor and low-income people, it was paying less and less to actually prevent them from getting sick in the first place. And so there was a major imperative to do something about it. So as I said earlier, there are two ways to try to tackle, at least in a big sense, the cost way. One is, can you regulate costs? And the other is, can the market innovate in such a way to actually, as markets are supposed to do, lower the cost of care? And so we did both in Massachusetts, and we did them kind of on parallel tracks. So I want to take you through the regulatory track, and then I want to take you through the market track, which I think ultimately had a greater impact. And so as part of our '06 law, the state was collecting a lot of price information from hospitals, and they had it in this database, and then somehow it got leaked to the major metropolitan newspaper in Boston. And so for the first time, really, people were seeing this kind of chart, which shows the price or cost disparity for common medical and surgical procedures at hospitals in Massachusetts. So you can see places like Mass General and the Brigham and academic medical centers in Boston. First of all, there was great disparity among them, but there were a lot more than community hospitals. And so while this was broadly known, it started to get known in a much more specific way. And then our state attorney general decided to take that and display it in an even more compelling way. And so this is a list of every acute care hospital in Massachusetts. And you have the academic medical centers in red and the community hospitals in blue. And this was probably for kind of inpatient care, but they did it for ambulatory care. They did it for specific diagnoses and conditions. And it looked like this. And by the way, a lot of markets would look somewhat like this. But it was a little shocking to people in Massachusetts. And it was shocking, for example, if you were a community cardiologist, let's say, and you worked for one of these systems here in the blue, and across the street there was a community cardiologist that happened to be affiliated with one of these systems way over here on the page, your income disparity might be $75,000 or $100,000 a year, let's say on a base of $350,000. That's very significant. And that kind of information, that kind of transparency became public for the first time. And this chart was so influential, you know, we would have hospitals on this end of the chart come into a negotiating session with us and say, I want to move to that end of the chart. And it was simple as that. And so it was influential. And so the governor, when faced with this, and so now we have a new governor, Governor Deval Patrick, he calls all the leaders of the hospitals and the health plans into a room trying to, you know, talk his way through the problem and says, you know, this must stop. And he was really responding especially to small business complaints about their health insurance premiums, which were going up, let's say 15% a year, year over year. And he said, this must stop. And everyone said, you know, it's a really complicated problem, Governor. It's really complicated. There are a lot of, you don't really fully understand it. And he lost his patience. So he did the one thing that a governor in a state like Massachusetts could do. The governor in the state sets the rates for health plans like ours for small business, 50 and under, and individuals, and he just capped them. And so this great collaboration we had in Massachusetts suddenly became the great healthcare stand-up. They rejected our premium requests, even though they were actuarially sound. He had no basis to do it. He just rejected it. And, there were fights and lawsuits and all that kind of stuff. And eventually it kind of, compromises got worked out. But and one of the things that happened was another new law got passed. In fact, every 2 years since 2006, we've passed a new law around healthcare cost containment, trying to incorporate some of these ideas. And because the state has a lot more regulatory control over health insurance companies than they do over hospitals, they tended to look at us. There's something called the medical loss ratio. How many of you know what the medical loss ratio is? So that's the amount of money that a insurance company spends. It's the second worst term in healthcare after capitation, I think. But a medical loss ratio refers to the amount of medical spending that a health plan does versus the spending we do on administrative services. And under the Affordable Care Act, you may remember that the actual medical loss ratios were set by federal statute at 80% for small businesses and 85% for large businesses. But this was Massachusetts. And so, and some states, by the way, saw that and they said, those are impossible standards to meet. And they got waivers from the federal government to do 70 or 75%. Well, in Massachusetts, it was 90%. So we had to spend 90% of the premiums we collect on healthcare. Because again, that was where the governor had regulatory control. They gave us a break this year, it's going to be 89, but well above any federal standards. So government was trying to do its best to do something about healthcare costs, but it wasn't completely working. So at the same time, at Blue Cross Blue Shield of Massachusetts, we say there must be a better way. And actually in 2005 and 2006, knowing that the law was going to pass, knowing we had postponed the cost discussion, we started working on costs. And we knew that the greatest influence that we have as a payer over costs is the payment system itself. And the quality and safety movement was really growing now, and we were aware that there were a lot of disparities in the quality and the value of care. And so our then CEO gave me the assignment to develop a new payment model for our plan and for the state. So I did what all smart people do who work for a health plan. When you're given an assignment like that, we hired a consultant. So we hired a consultant. We said, scour the country and give us the best payment model that will both improve quality, because again, quality and safety movement was really gaining steam, but also slow the growth in costs. So what did we get? We got a 200-page report that said there isn't anything out there. And I don't want to discourage any of you from careers in the consulting space. It's a great place to be. And so we had to design it ourselves. So we actually took a team of about 20 reimbursement experts and actuaries and physicians and nurses and other quality measurement experts, and we put them in a room. We called it the cave. We said, basically, you may not come out of this room until you've solved this problem. And what they came out with was a new model of payment, and it was we looked at what had failed about fee-for-service. We knew that the fee-for-service model itself was a big part of the problem. We had to get away from fee-for-service. We knew that experiments with capitation had not worked out that well. We knew there was this new kind of pay-for-performance models that were in the market, and we had one of the most mature ones not doing the job. And so we came up with a kind of blended approach that we called the alternative quality contract. And if we ever thought it would have been such a big hit, we never would have called it that, because it's such a terrible name, alternative quality contract. In fact, if we had sent it to our marketing department, it would have come back as, Blue Breakthrough, or Blue Vision, or Blue Sky, because everything's blue in the Blue Cross system. Like our employees take classes, it's called the Blue Campus. I mean, everything's blue. And we actually tried to change the name, but it was too late, because the acronym AQC for Alternative Quality Contract had already stuck. We couldn't change it. So there it is. So what is this new model? Well, there's three major components. So it starts with a global budget, meaning we pay a fixed amount, like in old capitation models, but with some differences. So first of all, we have a fixed amount to primary care physicians and hospitals, to the extent they collaborate, per patient, per month, that we then adjust for the health status of the patient. So there's no incentive for physicians to choose the healthiest patients. In fact, physicians tell us they want the sickest patients because that's where the greatest opportunity for savings and improvement. We based it, and this was controversial at the time, we based it on the historical spending of the groups. So we knew we had to kind of entice physicians into this new untested model. And we said, we're not trying to lower what you're getting today, but we're trying to reduce the rate of growth over time and pay you for quality. Why was that controversial? Remember I showed you those great disparities in payments among the different hospitals? Some people said, well, you're baking in these disparities into your new payment model. So guilty as charged, we thought it was more important to change the model than it was to try to change the disparities. We decided that we wanted to pay for outcomes and quality and value, not for the volume and activity that the healthcare system has traditionally paid for. So we chose a group of 64 measures, and half of them, this is just a summary of them, half of them are on the ambulatory or outpatient side, half of them are on the inpatient side. There's no black box back at Blue Cross Blue Shield in Massachusetts. These are all transparent. They're all measures that have been endorsed by the National Quality Forum, and they cover process, outcomes, and patient's experience of care. And we weight the outcome measures at 3 times the rate of the process measures, because I think that's what people are most interested in. And then the other thing we tried to do, we tried to disrupt the historic relationship between health plans and physicians and hospitals over their partnership. So traditionally, hospitals and health plans every other year or so negotiate payment rates. And this is what the negotiations usually go like. The hospital says, we need a 15% rate increase. And the health plan says, well, we can only afford 2. And the hospital says, well, how about 12? And the health plan says, how about 2.2? And eventually they agree historically at about 5. And so the unit cost or price increase of hospitals and physicians was growing at about 5%. And utilization was growing at about equal amount, and that's how we got premiums growing at 10 or 15%. We said, let's end this every other year adversarial relationship. Let's have a 5-year agreement. Let's mutually invest in each other's success, and let's work together on behalf of your patients, our members, to improve the quality and lower the cost. Including, let's us as a plan invest in the infrastructure needs you have in order to redesign care so that it works under this model. And so when it started, of course, this was a new idea. Just a few groups of PCPs, a little over 1,000, covering about 300,000 or 350,000 of our members came in. There was even a lot of public attention to this, and I'll come back to why that happened. But there was still a lot of skepticism. The head of the State Hospital Association, where I'd once worked, said, this is too fast, too soon, we're not ready. And the head of one of the large systems said, you're going to restrict choice, because that's what happened with capitation. That was rejected, that won't work. And someone wrote a letter to one of the local newspapers saying, this is an ill-conceived proposal, it was tried before, it was called capitation, everyone hated it, don't try it again. But we had some early support, and it started working. And what happened when it started working? Suddenly, it became the dominant way that Blue Cross paid for our managed care patients in Massachusetts. And we now have 85% of primary care doctors and 85% of specialists working in this. And they work in academic medical centers like at Mass General Hospital. They work in community practices. They work in salaried practices, they work in non-salaried practices, and they work in low-income communities and in suburban communities and in rural communities. And so we've been able to make it work in a whole bunch of different places. And one of the keys that happened, and we talked about this morning, is that as it became the standard for the largest payer in the market to do, the physicians in these practices said, we don't want to operate one way for our Blue Cross patients and another way for our patients with the other plans. So they actually went back to our competitors and said, pay us the way Blue Cross is paying us. Because if we're going to be paid for quality and outcomes, that causes us to really redesign our care. We want to do it the same for anyone. So, like any good experiment, we wanted an evaluation. And so we wanted it to have credibility. And so the Commonwealth Fund philanthropy based in New York that does a lot of work in the policy arena, commissioned an independent evaluation done by researchers principally at the Harvard Medical School, but just in full disclosure included a few of our experts. And in peer-reviewed journals like the New England Journal and others, they found this kind of holy grail that we're all after in healthcare. Quality went up significantly and costs went down. And even in a recent study in JAMA that there was some spillover effect for Medicare patients who were being cared for by physicians who were operating in this practice. And it really made a difference. But in that study was kind of interesting because so spending for Medicare beneficiaries fell, but the quality improvements, because there were no incentives for it, were largely not seen in Medicare. And as one of the commenters on it, a guy named Paul Grundy, said, you can't get a free lunch. You might get some chips or some apples, but if you want the lunch, you have to be at the table, and you have to be in the table of quality. So what are some of the specific improvements? So here's what happened on cost. Now, some of these drops, and so you saw our goal was to reduce the rate of growth in half over the life of the original 5-year contracts we signed. So at the time, healthcare medical costs were growing at about 8%, and we wanted to bring it down to 4%. You see, we actually exceeded that. Now, you'll notice in our control group, they came down too. So why was that? Because costs were coming down generally. But the ones in our group came down faster, but more importantly, as costs started to rise in the control group, they rose much more slowly in our groups, which suggested that something fundamental was happening, that the physicians in these practices were actually practicing differently. So what were they doing? Well, they started with what I would call the low-hanging fruit. They first looked back, way back to those charts with the prices on it and said, where are we referring our patients? So for example, there is a well-regarded kind of community teaching hospital in Cambridge called the Mount Auburn Hospital. They have a strong cardiology program. They looked at their cardiology patients. They saw that about 40% of their cardiology patients were having their procedures done at the Mass General Hospital, which was significantly more expensive. If they could cut that in half, they could save a lot of money because then they're being paid on a global budget per member. So they first started looking at where are we referring our patients. Then they started looking at other kind of obvious sources of savings. Where are our patients going to the ER where they don't need it? And they started putting in new diversion programs. And then over time, as it got harder, they really started focusing on those 5% of their patients that drive 50% of the spending in our healthcare system. They're patients with real chronic illness. So what happened on the quality side? Well, again, we had this classic controlled experiment because we had a group of physicians not practicing under a payment model, and we had ones practicing under a payment model. So the light blue are the cohort that came in 2009, and the darker blue came in 2010. And you can see the dramatic improvements. These numbers represent scores, so I don't want to get into the whole measurement system, but basically those 64 measures, inpatient, outpatient measures, we aggregate those into a total score, with 5 being the best possible performance that any physician or hospital could achieve in that measurement area, and 1 as the lowest amount we think we would actually pay a quality bonus on. And you can just see that the scores have risen, but it gets harder the more they're in it. But for me, the best and most important evidence was from physicians themselves, because I am convinced of one thing, and I said this to the governor when he realized the progress we were making, and he wanted to expand this across the state. I said, it's not going to be political leaders or frankly health plan executives that are going to persuade healthcare physician leaders to change. It's only going to be other physicians. That's the only person they're ultimately going to trust in this. And so I started going out and meeting with groups of physicians who were working in the practice, and this is what I heard from Phil Gaziano, who runs a large practice in the rural western part of Massachusetts. We do have rural counties in Massachusetts. And he said, and they completely redesigned their care. You know, their primary care physicians run the same, see 4 patients an hour, see 35 patients a day, bill for every service. And suddenly the physicians were liberated. If they wanted to spend 45 minutes with a very complex patient, they could. If they wanted to just see 10 patients over the phone or online, or in other ways they could do that. If they want to see patients together in group visits, they could do it. Their physicians were happier, their quality improved. And when I went out and met PCPs in a low-income area in the city of Lowell and the Merrimack Valley, Northeast Massachusetts, they're caring for their patients better. And even, surgeons, kind of usually the last frontier on these kind of quality and improvement efforts, they're seeing a big difference too. And surgeons, orthopedic surgeons, showing up in the emergency room. One described to me, it used to be that what would happen, one of his patients would show up in the emergency room. He would maybe get a call and he'd say, admit them, I'll round tonight and we'll decide what to do tomorrow. And instead, he's saying when he gets the call, someone from the practice goes over to the emergency department, and in about half the cases, the patients don't get admitted anymore because they don't require an admission. It was just a change in the incentives that did that. So, yes?
In the big performance studies, they talk about the concern about the quality incentives in low-income and higher-income areas in terms of the ability to meet those quality incentives and strengthen, and actually widen the between hospitals and low-income versus higher.
Yes.
What's been the experience?
Yeah, so for those of you who haven't followed this issue, there's a concern that because it may be harder for a whole variety of reasons to achieve the pay-for-performance incentives with low-income patients who face a variety of other challenges, whether they're language or transportation or just other social and cultural issues, won't we actually exacerbate the disparities between those hospitals or physicians caring for richer patients and low-income? That's not been our experience. And so actually an analysis has been done that I think will be published sometime in the next 6 months that looks by zip code at social economic status. And we actually have seen the experience of some of our groups taking care, including that group in Lowell, low income, actually exceeding because on the quality scores. And so actually more equalizing their payments because they're getting higher bonus payments. So I don't want to say that those issues don't exist. I think they do. And that it is a challenge. But the risk adjustment or the health status adjustment really makes a huge difference in accounting for some of the social economic difference. Some people have proposed, don't you need an additional adjustment? Yeah, and thus far we think the answer is no. And again, we have a lot of experts in risk adjustment studying that. So it's a great question. Other questions just while we're on that? Okay. So I guess 3 areas as we think about this payment model in terms of key to success. One was really is about accountability. And so if we think about it, and I was having a conversation this morning about kind of early system formation in this market and how it's going, and I know Ralph is doing some kind of innovative work in this area. It's our view that a lot of the talk about integration and system formation in the past has not been successful because there hasn't been shared accountability for the patients. And so if you just change structures without putting some financial shared risk among the participants, you just get some opposition. Well, it's not my job to do that. Whose job is it to ultimately coordinate care? There's no billing code for care coordination, so I'm not going to do it. But once accountability was introduced among the system, that they really changed their structure to promote real integration. The hospital, which is always seen as a revenue center, suddenly gets viewed at a cost center. And you start thinking about whether it's preventing admissions, preventing emergency department visits. You think about diabetic patients or congestive heart failure patients differently. And so we thought that true accountability was essential. Leadership was really important, leadership and collaboration, and we did a lot of work educating, especially the physician leaders of these group practices. We have forums on a regular basis so they can share their experiences with one another. And then we provide a lot of support. I told you, new partnership between plan and hospitals and physicians, and so we have a whole array of support mechanisms, leadership programs, call centers for directly, so we have our member service representatives answering questions just for those patients who are in these new models so that they have a greater appreciation about it. But I think the single most important thing we did is that we provided actionable data to the practices so that they could change care. So we provide daily, weekly, monthly, quarterly, and annual reports on cost, quality, and utilization. And one of the areas that we've had the most interest is in practice variation. So I just want to show you. So we've looked at a series of about 65 different areas where there's well-known variations in practices in both high-cost areas. I'm going to just give you one example. And so this is, shows for patients who report to a primary care doctor or to a gastroenterologist with reflux disease, how often do they get an endoscopy? So how often does the gastroenterologist do a procedure where they look inside the esophagus to see is there early signs of Barrett's esophagus or some other illness? And so every dot on this chart represents a gastroenterologist in Massachusetts. So you can see there's no uniformity, that some never do it, some do it every time, and there's just variation. There's no pattern here. There's no best practice of when you should do this. And those arrows represent a group of 5 gastroenterologists who practice together, offices side by side, see the same kinds of patients, and one of them does it almost every time. And you could look at the practice and say, well, does that gastroenterologist get the most serious patients? Maybe. You know, you have to look at it. And we're not suggesting, by the way, there's a right rate. No one knows what the right rate is. We're just suggesting this ought to make you think. If you're a gastroenterologist in that practice, you ought to think about how do we think about when we do an endoscopy, an upper endoscopy for our patients with simple reflux disease. And this, I could show you the same chart for scores of different diagnoses, and it'll always look the same. And sometimes it's kind of simple. You know, there was a case where we showed a practice, a group of primary care physicians, and how often were they referring knee patients to orthopedists. And one physician referred every time. And so they looked at the data and they said, why do you refer your knee patients every time? He said, you know, I was trained 30 years ago. Knees are really complex joints. I just don't really know how to diagnose them. And it was a fair thing. He got retrained in, you know, and now he refers fewer of his patients. Other times it's much more complicated. Back to a knee issue. We showed a group of orthopedists their charts about when they give an injection into the knee of this particular, somewhat kind of controversial viscotherapy, which isn't even fully accepted by national orthopedic societies. And they saw, again, all over the place. And so they sat down with the orthopedists and they realized there were probably some cases which didn't require that kind of intervention. So this is the health plan giving information, not saying what the right answer is, but just showing the variation. And so finally, I mean, what we're seeing is really a fundamental change in our delivery system in Massachusetts. We have passed that tipping point where people are acting differently. So practices are changing their staffing models. One innovation is primary care practices are hiring social workers in the practice. So we're all hearing about more team-based care, and you think of team-based care as you know, having a nurse or nurse practitioner or a physician assistant, and that is very important as healthcare moves from an individual sport to a team sport. But they're actually having a social worker who's doing a lot of that work between the visit. You know, one of the leaders talks about the tyranny of the visit. We have to get away from the tyranny of the visit in medicine and move and think about, because what most of health happens between visits. So they're changing their staffing models. They're changing the way they think about patient engagement. So you know nationally, and I'm sure here there's a big focus on readmissions. Those 20% or so of patients who are discharged from the hospital and come back within a few weeks. Well, so one hospital for the congestive heart failure patients decided on readmission, they call every day. Every day. Are you weighing yourself? Are you taking your medication? Did you go to your follow-up visit? And then after a few weeks, every other day, once they see compliance is happening, they actually reduce their readmissions for congestive heart failure to 0. New data systems and new ways to communicate. Dermatology is a good example where according to experts, a lot of dermatology, simple dermatology that's seen in the primary care setting, a lot of it gets referred out to dermatologists simply because, again, the training wasn't there. So through telemedicine and having a dermatologist on call with the practices, they're able actually to assist kind of a curbside consult with the primary care physician and prevent a lot of those referrals. Now, I mean, the old days, everyone wanted to make the referrals. Now, again, they want to conserve resources. And then finally, different relationships between the hospital, the acute care setting, and the primary care or ambulatory setting. One of the chief quality officers, one of the hospitals kind of confided to us that under the old system, if a lab test was ordered in the hospital and the patient left before the lab test came in, nothing happened to that lab. It just sat there. But then once they were under this payment system, they realized that's a major problem. And so now those lab values are sent electronically to the physician's, primary care physician's office, because it may be an important result. It may actually say the patient needs to return to the hospital. That seems like a simple, obvious thing, but it is a fundamental change in practice. So while we're making these innovations in the marketplace, it's not as if the political environment was standing still, because that never happens in Massachusetts. And so a commission had been appointed in the state. The governor appointed a commission, knowing that paying for care was going to probably be the greatest lever to think about changes in quality. A commission on which I served that had physicians and hospital leaders and business executives and others, and they surprised everyone by saying that the state as a whole should scrap the traditional fee-for-service payment system and move towards the global payment system. And I think there was only the confidence. This was really a radical move, only the confidence, because we had 2 years of experience. But again, that wasn't enough, because we are a state with a tradition of regulation, so I have to give you another bill signing. So our governor, and there are no Republicans in this picture, I'll just tell you, we're back to a single-party state, signed a bill that actually set a cap, because even though there was a lot of promise and confidence in the work we and others were doing to slow the growth of costs, that actually sets a cap for the state spending on healthcare. And essentially says the state spending on healthcare can grow no faster than the overall state economy. And for the past decade in Massachusetts, and I'm sure here and around the country, healthcare spending has been growing at about double the rates of the state's economy. And so here we are again, kind of facing a lot of innovation in the private market and a lot of government accountability and oversight at the same time, but we're still doing it in a collaborative way. So this was a few months ago. This is a photo of a basement in a temple in Boston, a Jewish temple in Boston. And what you have out here are all these activists working for the Greater Boston Interfaith Organization, and standing up front, I'm kind of sitting down way in back there, are the CEOs. Ralph, you would be in this picture if this was happening in Pennsylvania. There's Gary Gottlieb, your friend over there, the CEO of Partners Healthcare, the CEO of Stewart Healthcare, my colleagues who run the other health plans, being grilled by a group of consumer advocates about what we're doing about cost containment. And it was, you know, occasionally tense, but mostly a really positive discussion. And I think, you know, all this has led me to conclude that we have to kind of embrace this quality and cost challenge collectively. And when we were starting this work, I met with a very sophisticated thinker who had worked on some seemingly intractable problems. He had worked on the reconciliation process in South Africa. He had worked on the kind of problems with the international food supply. And he said, when you solve tough problems, there's a temptation to kind of revert back to this famous, for those, some of you are too young to remember this, but this was a famous bumper sticker in the 1960s. It was attributed to Eldridge Cleaver, which said, if you're not part of the solution, you're part of the problem. But what this expert convinced me was that that was the wrong approach, that probably the bumper sticker should have read something like this: if you're not part of the problem, you can't be part of the solution. So I think it's our experience, we're all part of the problem. Health plan executives, political leaders, hospital executives, physicians, and patients. And unless we recognize that it's this shared problem, we won't solve it. So thank you very much. And so I'm happy to take questions. I know some of you may have to leave, but I think we have till 1:30 for those of you who want to stay on any of the issues in Massachusetts, other ones I didn't raise, or even, you know, what you think the Patriots' chances are to, you know, beat the Broncos on Sunday. Yes?
I'm curious about the risk adjustment
Yeah.
formula that you use. I actually don't care that much about the formula.
Yeah.
But
Good, because
I'm interested to know sort of who was at the table. Was that something that really was left to experts, or were there stakeholders of various kinds who were involved?
Yeah, so what we did there, and so you're right, because the health status adjustment is central to getting this right. And that was one of the failures of capitation. So what we did, we sat with the physicians and the reimbursement experts at the hospitals and the practices, and we modeled their previous year's data. And we showed them that, here, and we, by the way, we update the health status on a regular basis. So again, there's no risk to the practice that if they take sicker patients on, and as I said earlier, they want those high-cost patients, because that's where the big savings are available. And so, yeah, we modeled it for them and showed them. And I didn't report this result, but all the practices in the first year produced a positive margin, and they earned some quality bonuses. So part of what we were trying to persuade them is we're not trying to reduce your margin or your profits. We're just trying to encourage you to make that margin or profits more on quality than you are on volume. And they're doing that. And for a primary care physician, if you're getting at the end of the year, if your average income, let's say, is $185,000, and at the end of the year you're getting like a $20,000 bonus check from Blue Cross based on your performance, your group's performance against these incentives, that feels material. The other thing is that we weren't doing any of this on an individual primary care doctor, or for that matter, individual specialist, only on groups. And so they understood, so if you were the doctor in the practice that happened to have the sicker patients, you weren't going to be penalized at all. And I think that helped a lot. Ralph.
Thanks for that excellent overview.
Yeah.
One of the challenges always in these payment systems, whether it's capitation or others, is how do you really share the money? And it usually takes quite a bit of sophistication to get that kind of agreement. Did you have to kind of guarantee that everybody would be as well off as before? You just have gains? So how did you deal with that issue?
Yeah, so it is a really important question. The failure of capitation was in part because people lost a lot of money. And so people had that really bad experience. That was why we started everyone where they were. And we said our goal was for them, for their healthcare spending to grow at a slower rate. Under capitation, often, it was we want to take you down right away. So we didn't do that. And again, we were criticized for that. We said, partners is paid too much. Why aren't you taking them down 15% when you start? Well, we didn't think that was a constructive approach. So we said, we're going to, over a 5-year period, the rate of growth is going to drop, and we're going to give you substantial bonuses on quality. And that was enough to persuade them. And again, the early adopters did well, and we had that experience to show. And again, our only interest, we weren't trying to increase our margins. We barely have a margin in Massachusetts. There's a kind of an expectation that not-for-profit health plans in Massachusetts shouldn't really earn much of a margin. And so they accepted it and it worked. And I'm not saying it'll always work, and it's getting harder and harder every year. We just renegotiated those original 5-year agreements. Those are harder negotiations because we're continuing to try to bring it downward.
Just a thought, so do the payments go to large groupings, such as, in most of the country you don't have those large groupings. I mean, some work that Rob Burns has done, 65% of doctors in America in groups of 4 or less.
Yeah.
So how do you deal with the people who weren't part of a big group?
Right, so this is a really important question about the application of this model outside of Massachusetts, which has more organized medicine. Well, 2 things. First of all, this prompted them to organize a lot faster. So those who were still in small groups, this along with the kind of general technology challenges are causing. But in some cases, that group in the Western Mass are mostly small pods of 3 or 4 physicians that kind of got together in a virtual way. So we allowed them to negotiate a contract together and share in the savings and potentially the risk, even if from an ownership perspective. So it doesn't, I don't think it requires the kind of corporate entity to own or the physicians to be salaried. I think it's just the idea that they're going to kind of flip their practice and focus more on quality and value. But there's no question that this is going to take longer in other parts of the state, other parts of the country, although there are some other promising experiments. I don't want you to think that all innovation comes from Massachusetts, just most of it. No, no, but really, there's great experiments going on in California and other parts of the country. And this model, I mean, the ACO model that was written into the ACA for Medicare patients, actually our alternative quality contract is referenced by name in the regulations, in the ACO regulations, and the Center for Medicare and Medicaid innovation that I think you're going to hear a speaker from in the coming months, you know, they're looking at the same kind of models. I mean, there are lots of complex issues: risk adjustment, attribution. How do you attribute the? I mean, these are all big technical challenges, but they're surmountable, and we feel we've gotten past them to improve care. Yes, sir.
That a lot of primary care practices are being incorporated into larger hospitals.
Yeah.
Is there a risk that that would essentially capture the referral
Yeah.
reports and possibly increase costs?
Yeah. There is, and it's actually, the risk is done in Massachusetts because that's already happened. So I didn't bring my slides to kind of show you the market formulation, but about 80% of our payments to physicians already go to 5 organizations in Massachusetts. And so they're already very consolidated, and we thought this was going to consolidate them further. We knew that. And so people often ask me, aren't you worried that these large systems will have so much leverage that they'll be able to exact higher prices from you, which will drive costs back up? And my answer is no, because one, well, we'll push back very hard, but more importantly, there's now, as you can kind of hear both from the government side and the market side, such pressure in our state to keep costs down that I think the hospitals and physicians would worry that were they to do that, were they to use their market leverage to drive costs up, that the state would come in directly and intervene with them. And we even have some further consolidation that's currently being reviewed by the Justice Department in Massachusetts about, is it going too far? But if you believe in integration, and we do, and I do, and you believe that care needs to be coordinated, especially for patients with chronic illness, you're going to need larger systems of care to do it. I don't think those small practices that Ralph referred to can really work in that way to produce the kind of care we want, maybe in a virtual way. And so I don't fear system formation the way some of my colleagues around the country do. Yes, ma'am. So you have like 3 different questions there. Let me, but I have an answer for each of them. First of all, it did help, but it did help that we funded a $50 million e-health initiative in the state, and it helped wire some practices. I actually think that looking back on that, because that was a while ago, there was an overconfidence that electronic exchange of patient information would in and of itself cause a fundamental change in the delivery of care. It doesn't. In fact, we have some successful practices that their registries are still essentially paper registries. And so, obviously, do I believe in electronic exchange of information? Absolutely, and it's essential. And you know, my father was once, he cut his hand in his house, and you know, the ambulance came, and he said, well, take me to the Brigham and Women's Hospital. That's his hospital. And then Brigham and Women's was on diversion. Their ED was closed, so he went to the Beth Israel Hospital, which is next door, literally next door. And they got in the emergency room, and they started asking him all these questions. He said, well, you know, just get my files, you know, from the Brigham. And well, we can't do that. They could have opened the window and shouted out, you know, could you send Mr. Dreyfus's files over? But, you know, they couldn't do it. So we definitely need that exchange of information, but I think overconfidence. Beware of confidence. In terms of the trust of the data, first of all, they need the data, and we use a third party, a group called Focus Medical Analytics, which is based in Rochester, New York, which is led by a physician named Howard Berman, which has done a lot of the pioneering work in small area analysis and how you do it. And so we bring Howard out and other physicians. The physicians leaders get this. Individual physicians, they may not trust our data, but when they hear it from when those 5 gastroenterologists heard it from the chief of gastroenterology of that practice, then they believe it. And you know, it's interesting, I'm sure there are a few physicians in the room. These physicians are used to getting A's their whole life, okay? And so if this looks like a B- to them, they want to change. I mean, they want to provide the best care. And that doesn't mean that they immediately you know, change their practice, but they'll change. Yes?
What about lumpy capital costs for HIT, for healthcare IT?
Yeah.
Partners is about to spend $1.4 billion.
Yeah.
And the other hospital systems comparable amounts on buying Epic and
Yeah.
Epic and Epic.
Well, Epic and Epic, yeah.
How does that factor into their cost basis, and
Yeah.
how do you reimburse?
Yeah.
taking that into account?
So it's a really good question. So early on in our early practices, we have actually made direct infrastructure payments to the primary care practices so they could develop both electronic infrastructure as well as the kind of other services, nurse practitioner and other services. You know, it's built into the base of the system. I mean, a place like Partners obviously has the financial resources and the endowment to do this. I think the tougher question that maybe you implied there is, are they so, do they have the resources that others don't? And will we kind of still have these big disparities because the others don't have the financial resources? We think they mostly do. It was interesting. So there was a very large practice in Greater Boston called Harvard Vanguard Medical Associates that had a 30-year relationship with the Brigham and Women's Hospital for inpatient care. And once we put in this new payment model, they looked and said, well, we can send our inpatients to the Beth Israel and it'll be about 15% less and they'll get to keep the difference. So they disrupted a 20 or 30-year relationship. The question was, how could they get online with there? Back to my father's experience. And it turns out, John Halemka, the CIO of the Beth Israel, came up with what the doctors at Harvard Vanguard called the magic button, where they could hit one. So sometimes the expensive IT interventions are not always the best, as our federal government learned when they set up the exchange. And frankly, as the Massachusetts government is now learning, because we had a really well-functioning exchange, and then the feds came in and now our exchange is broken. So $68 million later, yes.
How important is the economic instruments, for example, the cost-effective analysis and the qualities are being used by the physicians nowadays, or it's just for the books?
Yeah, well, yeah, so I think what you're asking is, are we kind of essentially teaching to the test here? And are we getting what we paid for? And are we only paying for the quality improvements? Are they only making the changes on the things we're paying for versus the other things? Or are you asking more, are they applying cost-effectiveness criteria to the interventions they're doing? Yeah, I mean, they're starting to. I think there are some good examples in stroke care where they looked at this variation data and they looked at some very expensive interventions they were doing, including medications, and they stopped doing some of them because the cost effectiveness wasn't there. I mean, back to the question, do the physicians really buy the data? I mean, cost effectiveness is the last thing they're going to accept. It's the last thing because every patient's different, and we get that, and that's true. And of course, as we get into kind of personalized medicine and genomic medicine, in fact, that will be true, that every patient will be treated somewhat differently. But what I thought you were asking, but I'll just comment on it because I think it's important, we do get asked a lot in addition to the kind of socioeconomic question is, well, are you just getting better care for what you're paying for? We're paying for diabetes and congestive heart failure and cardiac care, but what about rheumatology that you're not paying for? Or what about oncology that you're not paying for in a big way? But what we're convinced is that if you change your practice to perform well on these 64 measures, then you have to change it for everything. That the structures you put in place to take care of a diabetic patient well will be the same structures you'll put in place to take care of a rheumatology patient well. So, I mean, I think that's an open question and we'll learn more. And by the way, this is, I don't want to say this is a perfect system, our payment model. And one of the things that we also include are developmental measures. So if a practice wants to have some things they want to test, we'll test them with them. We have one of these contracts with our children's hospital. We had to create a whole set of pediatric measures. There aren't 64 measures for kids. It took us 2 years, but now we have the first pediatric global payment arrangement with our children's hospital, which has a big imprint in our community, and we're really excited about that. Yes, sir.
What is your approach to integrated care?
Yeah.
And the necessity of cooperation. Very interesting and very all the market innovations were really very persuasive. Now, in that motto that you have, if
yes.
you're not part of the problem, you cannot be part of the solution. I think when it comes to healthcare, you would probably put it, if you're not part of the long-term problem, you cannot be part of the sustainable solution.
Yes, right.
So the issue is sustainability. And there's a question, and this would apply at the national level as well.
Yes.
In getting stakeholders together, if you look at with globalization,
yes.
two dimensions. Globalization of democracy and globalization of the free market system.
Right.
Both of these depend on the idea of a free society.
Yeah.
So that's where the conundrum is, because society cannot exist without caring for the other.
Right.
But why care for the other if you are free not to?
Right. Well, and it's a great kind of philosophical point, but it gets back to what I said at the beginning of how do we balance the role of government in healthcare and the role of the free choice. Where I thought you were also going to go is long-term and sustainable is, again, most of this, what I described to you, is about acute care. And the most sustainable solutions, back to the social determinants of health, are actually in the public health arena. And on a global basis, that's where a lot of the interventions are. Although I'm involved with a new group, Ariadne Labs in Boston, which is trying to bring some of these solutions to high-cost, high-risk procedures in India and in Africa and different states. And again, trying to bring greater uniformity to care is part of the solution there. Yes?
Can I follow up?
Yes, please.
The problem here is, who does the balancing? Because there are conservatives and there are
Right.
liberals, and there's majority-minority conflict. How do you address that?
Yeah. Well, I mean, obviously, our political system ultimately has to kind of rationalize it. And I guess the case I tried to make is that in Massachusetts, we've come up with a balance that we're mostly comfortable with. And I think we'll end up there in the middle. It's been interesting watching the system in the UK, which was a completely government-mandated system, and they're actually introducing more market mechanisms in. And there's actually a group in Scotland who's using our measures and models in their practice. And so, I mean, I'm placing myself kind of squarely in the middle there. We need government oversight and protection for the sake of especially the poor and the vulnerable, but we can't do it at such a level that we're going to kind of squelch innovation. I think that's what they discovered in the UK. And I think, Germany has a kind of interesting model too, where they have these sickness funds that are a lot like Blue Cross plans. What's common with all the Western European models is the government sets a budget for healthcare. And then the providers and the plans live within that budget. That's the one thing we are very reluctant to do in the United States. It runs counter to our sense. And when you look at one of the best things I've ever read about the difference between the Canadian and the US system went back to the Canadian Constitution, which is apparently, as I've never read it, but it's written all about trust in government. Our Constitution is all about mistrust, right? The balance of power at the federal level and then the federal to the states, and we're actually seeing that play out right now. And as we discussed earlier, I mean, the ACA anticipated a national solution to healthcare with a little variation by states. No one anticipated that 36 governors would say, no, we're not going to run our exchange. No, that we were not going to accept Medicaid, that we're going to cancel policies that allow them. So it's going to turn out in the United States that we're not going to have one system. We may have kind of 5 variations of what the ACA looks like. And that may not be a bad thing, because in our country, it may be the state that is a better locus of accountability for healthcare than the federal government, because it's closer to markets and it's closer to the people. And so it may be that in a nation as big and diverse and politically divided as ours, solving a problem that's as personal as healthcare, but as economically important as healthcare, the federal government may not be the best place to do that. I'm not ready to concede that yet, because our Medicare program, by and large, runs so well. But that may be part of the answer. I think we have time for a few more questions. Yes.
So thinking about ACOs.
Yes.
And, with the alternative quality contract, there's papers that show this fact, and
Yeah.
there's a lot of people around the country that are saying, okay, I'm an ACO, and I'm going to expect the same results that were in
Yeah.
this paper. So, it makes me nervous. I don't know how you feel about that, but
Yeah.
I guess 2 questions. One is, do you think of what you did as an ACO, and then what do you see as kind of, I saw your keys for success. I
Yeah.
thought that was really important.
Yeah.
And then what's your faith that, some of the, the keys to success that you've seen might be reproducible?
Yeah. So I would say basically, although there's some modest differences, that we do view our model as very close to the ACO, the Accountable Care Organizations under Medicare. We do think that, the Medicare population is different, is a different population. So this is a under 65 commercial population. And so we have to be careful about, fully applying some of the lessons. Though there have been a series of Medicare demonstration projects around the country, some that have been going on for 10 and 20 years. One's in Minnesota, one's in Pennsylvania, Health Quality Partners, the work they do here. Is that their name? I was just in Washington this week, and I met with them. So I am confident. I think there are some problems in the Medicare problem around the attribution and the data lags. And back to who should run some of these. We're giving data on a daily basis to these practices. Medicare, they can wait months and months and months, and then they get the feeds of the patients, and some of the practices look at them and say, 25% of these aren't even our patients. And the attribution is done retrospectively. And then Medicare is so slow in evaluating some of these, and I would ask your CMMI representative when they get here. I think I have more confidence that if Medicare just continues to drive this way, that the commercial market will adopt it and then move past it. And then it'll become the standard of payment. And so I fully expect, and it's going to take a decade, and we should give it a decade. We could move faster by this kind of confluence of circumstances in Massachusetts around our coverage reform, around the political environment, and around the high cost and the economic imperative. But I fully expect that over time in this market and others, this will be the dominant form of payment. And so I feel like these lessons are translatable, but with caveats, and we'll learn and we'll get better, and ACOs will get better and we'll get better. Yes, sir.
Why are procedures generally so much more expensive in the U.S. than they are in other industrialized countries?
So the U.S. reimbursement system has historically overvalued procedural interventions and proceduralists in general, whether it's surgery or medical procedures by medical specialists. And it really goes, the answer, I think, to many goes back to Medicare. Because most commercial fee schedules really are set off the Medicare fee schedule. And the Medicare fee schedule, there's, the most powerful group you've never heard of is something called the RUC. Anyone heard of the RUC here? So the RUC is a group of physicians chartered by the American Medical Association that evaluates how Medicare sets its fees. And you won't be surprised that there are more specialists on that group than there are primary care physicians. And look, there are some reasons for that because, of course, specialists train longer, and there are all these studies, including some landmark studies done decades ago at Harvard School of Public Health by William Shao on what is the kind of economic inputs into a surgery versus a medical evaluation. But what you see under these models and what you see in other countries is that we don't have that huge gap, and the kind of cognitive specialties, primary care, pediatrics, psychiatry, this is one of the reasons that behavioral health and mental health is the stepchild of our medical system. They're valued in a greater way. And what happens then, of course, is the distribution of the specialists versus primary care changes as well. Because if the incomes are, it's not surprising if you come out of medical school with a $200,000 debt and you have a choice of, a procedural specialty, let's say, interventional cardiology versus, primary care, that the income difference could be, Ralph, 2 or 3 times. And so that too is going to take a long time to change. But again, primary care has a central role in our model, and no one asked, well, how are we distributing these surpluses that get created through the bonus mechanisms? And we actually left that up to the physicians. And as a consequence, primary care is going to have greater value over time, and specialists will have somewhat less value. And I think we'll even see some medical specialists start to retrain in primary care. And that could rebalance, but that'll take, again, half a generation probably to fix.
One real quick question.
Yeah.
So how confident are you that this is transportable nationally, given how physicians have responded to this? And my only point of reference is about 20 years ago, I introduced Jack Wenberg's decision-making model across the U.S. And I remember being with a group of Denver urologists who were furious.
Yes.
Saying, my God, this came out of Massachusetts.
Right. Well, Wenberg came out of Dartmouth in New Hampshire, but yes, I get the idea. No, I get the idea. No, I think there will be a certain amount of skepticism. There is already. And as I told you, it really will be physicians persuading other physicians that they're doing better by their patients. Their income has not been harmed. Maybe it's even been improved, and they're taking better care of the patient. That's, I think, the only test that will satisfy physicians. If not, they'll be understandably skeptical, and I get that. But when they say, I like practicing better, that group in Western Mass are recruiting physicians from other states to come to Massachusetts because the style of practice will be better for them. And I think as the news of that spreads, it'll help persuade some of them. But again, and there's a generational issue in here too. I mean, the physicians who were trained and were guaranteed high income, great autonomy and independence, and huge community respect. And the younger physicians, and I met with one here today, who were being trained in team-based care, being trained in evidence-based care, understanding data and analytics, working across specialties to improve care. They're going to have a different approach, and so that's why it's going to take a while.
Thank you very much.
Okay, thank you so much. Yeah.